Session for Public Health 101. We are going to be hearing from the Oral Health Program, Dr. Sam Swetchkenbob and Sadie DeCourcy. All right, guys, if you're ready, go ahead and take it away.
Okay, good morning. So let me see if I've got this in the mode that we need it. Right now, it should look like presenter mode.
You are good.
Okay.
Looks great. I didn't realize we were the second to present, so the pressure's on. We got to start everything off right, which I'm sure, Jen, you did last week. But good morning, everyone. As Jen said, my name is Sadie DeCourcy. I am the Oral Health Program Manager here at the department. I have been in that role for about 4 years or so, and before that, I was the Perinatal and Infant Oral Health Coordinator, and I'll be talking a little bit more about that work in the coming slides. And I'm joined today by Sam Swetchkenbob, who is our Dental Director, and he will introduce himself again, but he is split between Medicaid and the Department of Health. So that provides the state with a really interesting opportunity to bridge that gap between Medicaid and the Department of Health. The next slide, Sam. So here are our learning objectives for the day. First, I'm going to tell you a little bit about our oral health program and what we do, as well as kind of take a little dive into our department as a whole, and you'll see some very familiar slides about what we as a department focus on in terms of health equity. Sam is going to do some review of our data of oral health disparities in Rhode Island, as well as describe some of the work that the oral health program is doing to achieve oral health equity. We will then dive in and discuss a little bit about community health workers and how we're utilizing them to improve the oral health of Rhode Islanders. Now, if you don't know what community health workers are or CHWs currently, you will know by the end of this presentation, I promise. So next slide. This is the oral health program's mission and how we hope to achieve that. So I'll let you read our mission, but overall, we want to make sure that all Rhode Islanders, no matter their zip code, have access to affordable, high quality oral health care, and that we can eliminate disparities with that. Now, some of our focus is through prevention, working with all different kinds of partners, both at RIDOH and across the state. We do not discriminate. We want to work with everyone and anyone, because if I have you take away anything by the end of this presentation, it is that oral health is a part of overall health. No matter what discussion you're having, no matter what table you're at, oral health can be a part of that discussion. Another piece of the puzzle is documentation of the burden of oral disease in Rhode Island. That's looking at the data that Sam is going to talk about in a little bit. And then again, as I mentioned, through collaboration with anyone who's willing to work with us, we hope to achieve our overall mission. Sam, next slide. This is our small but mighty team. It is myself as a program manager, our epidemiologist, Epa. Veronica is our sealant and fluoridation coordinator. Jen Ritchie, who also splits her time with the Academic Institute, is our Health Professions Experience Coordinator, and Sam, our Dental Director. Next slide. Now, when I was talking about our collaborations, I wanted to give you a sense of how we work across RIDOH. So this is a little bit of an outdated org chart, but as you can see, we are located under the Division of Community Health and Equity in the Center for Preventive Services. That doesn't mean that we don't work with almost every other division, including the Division of Environmental Health, where we work with the Center for Drinking Water Quality in terms of water fluoridation. We also have worked with the Center for Healthy Homes and Environment, working with their lead program. There's the Center for Professional Licensing Boards and Commissions, which is under the Division of Customer Services. And that is the dental board and any kind of licensing that our dental providers have to go through. We also work with the Division of Policy, Information, and Communication. Anytime we want to push through legislation or we want to talk about changes in regulation, we work with that division. And I will say one big win for us is that the Medicaid dental rates for adults were included in the budget for the first time in forever. And they are actually going to be raised, the reimbursement rates, for the first time in 30 years. So if you want to talk about a public health win, that is it. So we are very excited to be starting to implement those changes. Next, Sam. And just very quickly, we also sit on, just to go further, under the Center for Preventive Services, you can see all the other programs that are under the division and particularly under our center. And we all meet regularly and work to coordinate our efforts. Next. And this is the couple of slides that I said you guys will probably find very familiar. And I won't repeat any of it, but again, just to say that oral health can be put into any of this. It is the cause and the effect of a lot of these leading priorities and overarching goals. Next slide. And again, this one probably looks very familiar as well. The equality versus equity. Our goal is to get rid of any kind of inequities that might exist so that we end up on that third picture where everyone has access and all inequities are addressed. Next slide, Sam. And there are a lot of factors that go into that. It's not just making sure you go to the dentist twice a year or making sure you floss, which you should. There are many other pieces to the puzzle that create good oral health for a lifetime. And just some of them are the access to care, hygiene, behaviors, which can be influenced by your family or the environment you grow up in. And I will put a plug in for access to fluoridated water, which Sam will talk about later. Drinking tap water is very important. Next slide. And just to get us started on the data, and then Sam's going to take over, this slide is very impactful to me personally. When I first saw this, I couldn't believe how many millions of hours are lost, particularly in schools, for children who have dental issues. 51 million hours across the country are lost annually. And that, you know, just think about if you've ever had a toothache or, you know, something that's going on in your mouth, braces. Every time you got those braces tightened, that pain you felt, some kids feel that all the time and they can't pay attention. They have to go to extra dental care, which then loses those hours. And it's the same thing for work. If you don't feel comfortable in your smile or in how you speak, that can impact finding a job, keeping that job, sick leave that you need to take, any kind of job loss that might happen. All right, and then now I'll turn it over to Sam.
Okay. So here, a little vibration. Oh, that's better. So it's great to be with you all. As Sadie says, my name is Sam Swetchkenbaum, and I've been here at the Department of Health for about 5.5 years. I was previously in clinical settings, including, often I'll point out the window. My first job was at Capitol Hill Health Center, just down the street at a community health center, and I've also worked in hospital settings. This is probably not the most beautiful picture to look at first thing in the morning, but I show this is a cavity or tooth decay, or in dental parlance, we might say dental caries. Dental caries is actually a process, and it starts with a bacteria. That bacteria is called Streptococcus mutans that consumes a sugar, converts that sugar into an acid, and that acid breaks down a susceptible tooth, a tooth that has not been properly protected by fluoride. So we want to obviously avoid tooth decay or dental caries or whatever term you want to use. And the way we focus preventive efforts is really hitting each one of these. Brushing and flossing and good oral hygiene addresses bacteria, talking about nutrition, reduces sugar, and community water fluoridation strengthens teeth. I wanted to show you this too because this is one of several dental diseases. there's also periodontal disease, there's oral cancer. This is the one we'll probably, through our data, be talking about the most. So I just wanted you to have a picture for what we're talking about through dental caries. And I think you can appreciate that's pretty deep. There's a what we call a pulp chamber inside the tooth that can become inflamed from the proximity of the bacteria, and bacteria can actually get into the tooth and actually travel systemically, and it can have devastating effects. This was a huge wake-up call to not only the dental community, but the health community. This is a young man who died due to a brain abscess from the tooth. And ultimately, we realized that our health center system was significantly lacking in resources. And I'll share with you a little later some of our safety net clinics. So as Sadie mentioned, one of the things we do is we collect data so that can drive some of our decisions. There's national data that looks at several things, or a whole series of things, but we also have Rhode Island components. So our Rhode Island oral health surveillance system is composed of surveys, which surveys are forms that people fill out, or calls that people get that ask them questions. And these are done, as you can see, either every 2 years or every 4 years or annually. And this is a big source of data. It reaches out to a lot of people. The other source of data is screenings, and that's where dentists and dental hygienists go into settings and actually examine a sample of children or older adults. And currently, we're looking at data on our kindergarten and third grade, what we call basic screening survey, and I'll share with you some data there. And while this provides very robust and very precise data, it's a lot of work to get done. Other sources of data is Medicaid claims data, hospital discharge data, licensure data. So there's a lot of data, and like I said, we need to watch this and see what's going on. But one of them that I mentioned is the BRFSS. If you're not familiar with that, that stands for the Behavioral Risk Factor Surveillance System. And this is a phone survey with many, many components. And just to give you an example of one dental question, it says, how many of your permanent teeth have been removed because of tooth decay or gum disease? And we are able to track from this, we're able to track proportion of Rhode Island seniors 65 plus who've lost all of their teeth. And here's actually some good news. It's gone down over the last 20 years from 26% of people over 65 to just over 11% in 2020. So our image of the older adult with a denture and a glass by their bedside, that's largely a thing of the past. However, I will say, and I'll share an example a little bit, when we break it down and we look at things by education, by race, ethnicity, by wealth, we see disparities. And again, that's one of our goals, is to eliminate disparities. Another thing that we look at is from the BRFSS is what proportion of people had a dental visit in the last year. And we consider having a dental visit annually as critical to check for any problems before they become problems and get critical preventive measures. And so in Rhode Island, overall, 74% of adults reported having a dental visit in the past year. Now, when we go ahead and break that down, we do see some disparities. So we see in the top, in the orange, you can see disparities based on race and ethnicity. So 75% of white non-Hispanic adults reported a dental visit in the past year. This is actually from 2018, but only 62% of Hispanic Rhode Islanders. So again, we see differences based on race, ethnicity. We also see differences based on education, with people who are have more education, more likely to have had a dental visit. And as you're probably running through your head, why might that be so? A lot of that has to do with access to dental insurance, and many jobs that people who don't have a college degree get. For example, certain day laborers or people who are working in home health situations may not get dental insurance. So their ability to seek dental care is impaired. So again, this points out the importance of a robust Medicaid benefit. Again, I won't go a ton through BRFIS, but I encourage you to visit their website, and we'll have more data. This is also a really cool tool from the CDC called Places, and you can actually focus in on your community and see some differences. So on the left side, that's what proportion of people had a visit to the dentist. This is people 18 and over. And the very light areas, it's less than 54%. So people who are in areas like Olneyville or Central Falls, you can see those areas are very light, were much less likely to have a dental visit than people on the east side of Providence, for example, or in some other areas. Similarly, and it's I hate to say it's almost a mirror image, is all teeth lost over 65. That people in areas such as Central Falls or Olneyville, almost 1/4 of adults over 65 are missing all of their teeth, compared to less than 10% on the east side. So again, it points to the fact that seeing a dentist regularly does make a difference. Another source of data we have is the Youth Risk Behavior Survey, or YRBS. And again, the exciting thing about this is that you can do cross tabulations, and I encourage you all to play with this, but there are several oral health questions. One of those oral health questions is, did you have a dental visit in the past year? And we see, about 20% difference in terms of people saying yes based on race and ethnicity, with white teens 20% more likely than Black, non-Hispanic, and Hispanic Latino Rhode Islanders to say they have a visit. Even more concerning, that gray bar represents people who it's been more than 24 months or never, and we see 3 times as many among Black, Hispanic, and 2 times as many Black, non-Hispanic, and 2 times as many. So again, this is data that hopefully we can use to inform some change, and I encourage you to explore deeper. The one that I said that we're just finishing up now, and this is, I will say that this is preliminary data, is our basic screening survey. And we had a whole core of dentists and dental hygienists who went into schools that were especially picked out to get a good distribution. I had the pleasure of going into a number of Providence schools, and we look at both treated and untreated decay. So treated decay would mean they have a filling or they have the tooth removed. Untreated decay is they have an active tooth decay. And then decay experience is people who have either tooth decay or untreated or treated tooth decay. So good news that decay experience by grade, which is kindergarten and third, on the left side is Rhode Islanders, on the right side is national, and we do slightly better. So our decay rates are slightly lower than national. So that's good. But when we look a little bit more closely, again, we see differences based on race and ethnicity, with Hispanic, Latinx kindergarten and third graders having the highest rates of decay experience. And we also see higher rates among male and higher rates among third grade. The other one that I'll show you is based on urban, non-urban. Okay, so significant difference between urban and non-urban in decay experience. And then when we looked based on a measure for socioeconomic status, is the proportion of students on a free or reduced school meal program. So the higher rates of students on free or reduced school meal programs is lower SES. And we see the top bar is low SES and has highest rates of dental tooth decay experience. The other thing we looked at is untreated tooth decay. And these are children who are going around with an active tooth decay. And this also represents access to care. Again, significant, probably 1/3 higher among Hispanic, Latinx than white. And if you look on the right side, again, based on urban and socioeconomic status, we see pretty big difference. So that's important data to look at. A lot of this data, certainly in the past, has driven having a more robust Medicaid benefit. And I'll talk a little bit about that in a bit. But the children's benefit, Right Smiles, really pushes to get better dental care for children. I showed this graphic earlier about the components that go into dental caries. This seems quite simplistic, and it really is. I more recently have seen this is much more robust, and it's a little harder to read. But what it shows is this: those three circles sit in a very small part of what influences. There are child level influences. Does the child have access to dental insurance? There's family level influences. Do the have the parents had dental care? Because we know if a parent is not able to access dental care, they may not get the same education to help their children, or they may not value dental care in the same way. And finally, there's community level influences. Is it easy to access healthy foods, or does somebody live in a neighborhood where they're assaulted by advertisements for Coca-Cola and cigarette smoking and things that are commercial and bad for oral health? And a lot of where people live and a lot of the jobs that their parents may have or that they have is based on a history of structural oppression and institutionalized racism. So this is really a key example of work that needs to be done to address on many areas. So improving people's housing ultimately can help children's oral health, so they're safely drinking fluoridated water, and much more. So it really does fit into so much of the work that we're doing here at the Department of Health. I wanted to show a couple more examples of data. Again, we probably could spend all day together on data, and if you'd like to do that, send me an email. This is an example of emergency room costs. The biggest failure in our dental care system is when somebody has to go to the emergency room for dental care. You actually don't get care there. Maybe you get an antibiotic, maybe you get an opioid, but it means that somebody does not have a dental home. And while we did see those numbers go down from 2014 to 2018, we do see people with Medicaid are still going in large proportions to the emergency room. The other thing more concerning is when we look at that data based on race, ethnicity, and look by proportions, we see that Black Rhode Islanders were 3 times more likely than white Rhode Islanders to go to a hospital emergency room due to dental pain or infection based on rate per 10,000 people. And that, again, is a reflection of not having a dental home, being in jobs with poor access to dental insurance. Okay. The other piece of data, I promised I wouldn't show any more data, but I keep going. But this is PRAMS, which is the Pregnancy Risk Assessment Monitoring System. And I show this because Sadie's going to talk in a little bit about how critical it is for pregnant women to go to the dentist and have good oral health. That horizontal line you see is the Healthy People 2020 goal of 49% of women having dental cleaning during pregnancy. And in Rhode Island, we beat that by a few points. Yay. But if we look a little bit more closely, we see people with no high school education, are below the bar. People who are who have no insurance or Medicaid insurance are below that bar. People who are Hispanic, Latinx, or Black are at or below that bar. So definitely there's still a lot of work to be done. Okay, so I wanted to just go through some of those examples of what we do to try to address disparities, and just we'll be able to go through a few, but like I said, I'd invite you to spend more time with us. We support our health centers. We support evidence-based preventive measures such as community water fluoridation and sealants. We support a robust Medicaid benefit, and we have initiatives to support our dental workforce. So we're fortunate to have eight health centers in Rhode Island with 14 dental clinics. And where you see these blue stars are where health centers are located. And we frequently work with the health centers, checking in with them, but also on various projects to advance medical dental integration. Medical dental integration means that we're collaborating on efforts to get referrals for dental from the medical side. As I mentioned, community water fluoridation, it's considered by the CDC to be one of the top 10 public health achievements of the 20th century, along with vaccination and safer workplaces. So I'd like to take a few minutes to go over what is community water fluoridation. These are slides developed by the American Academy of Public Health Dentistry. So the history is actually really fascinating, that it was over 100 years ago that Dr. McKay in Colorado discovered that there were children who had a brown stain on their teeth. And they found that these children were drinking from a well. Ultimately, they found out there were high levels, about 14 parts per million of fluoride. So that's 14 milligrams per liter. But at the same time that they had this stain, they had no tooth decay. So this led to the hypothesis that there was something in the water that caused the stain, but also something that was preventing tooth decay. When they took a deeper dive and started looking at it, they realized that it was fluoride. And they started looking at levels that were much, much lower than what caused that brown stain, closer to 1 part per million. And they looked at cities around the United States at different levels. And then they did what's called a 4-pair city study. They had over 15 years, they had pairs of city, Muskegon, Michigan, and Grand Rapids, Michigan, where Grand Rapids was fluoridated and Muskegon was not. And there are three other pairs. And ultimately, the U.S. Public Service Health Service issued a policy to support community water fluoridation. So what is community water fluoridation? So it's where you adjust the level of the fluoride in the water supply. So most natural levels here in Rhode Island are about 0.3 parts per million. To do community water fluoridation is to adjust up to 0.7, which is now the recommended level. So adding a small amount to bring up to 0.7. Previously, it had been a range, but that's now the recommendation is 0.7. Most water supplies do contain a trace amount of fluoride. Water systems that are considered naturally fluoridated, when the natural level of fluoride is greater than 0.7 parts per million, no additive is required. We have some communities where that's true in Rhode Island. Okay, so that's what water fluoridation is. What fluoride does is so how does it help? It basically does 3 things. It makes the enamel more resistant to demineralization, and that works by converting hydroxyapatite into calcium fluoroapatite, so the enamel is less soluble. It also interacts with the bacteria by actually causing bacteria static. It stops the bacteria, and it also, during development of the enamel, it makes the enamel less soluble. So here through a graphic, you can see that it makes the tooth smaller. stronger. Sorry, gotta turn this way. So fluoride, like I said, makes the tooth stronger. And what they found over the years, they look at this measure called the DMFT rate, the decayed, missing, and filled teeth due to dental caries. In the United States, it's gone from 4 in 1966 down to 1.3. They attribute that improvement, 50 to 70% is due to fluoridation. Caries was reduced among adolescents. And this is considered an equitable measure because it does not require costly health services for a health professional to deliver. It's available to everybody. There are no daily dosage schedules to remember. So students or young people who live in South County, for example, in Rhode Island, I'll show you a picture, they don't have access to fluoridated water, so their parents are recommended to take pills. So to have to remember to take those pills can be difficult for families. This is data from the United States, again, showing as the proportion of people on fluoridated water has gone up over the years, the decay rates have gone down. So it's pretty significant. In the United States, a total of, in 2018, a total of about 63% of the population received fluoridated water, or 73% on community water systems. And I'll show you Rhode Island data in just a little bit. I did mention this dental fluorosis, which is kind of how it was first discovered. We do watch closely for this. Mild is what's seen on the left side. And when I did do the school screenings, I found when I was in Providence, there were some children who did have very mild levels of fluorosis, but again, no decay, which is great. What you see there on the right is very, very rare in the United States. In fact, the only time I've seen this in my clinical experience was from young people who had been, who had come from Ethiopia, where the levels were about 14 parts per million. And again, we do not reach that at all here in Rhode Island. We get the data. Veronica Rosa da Fonseca gets the data every month. We look at it and we see that systems are very compliant. We do have to deal with communications. There are anti-fluoridationists who reach out to try to engage the public in often some misinformation, just like there are anti-vax folks. So we have communications set up through the oral health program to educate community leaders so they have the information they need to continue to support fluoridation. Here in Rhode Island, 84% of the population on a public water system gets community water fluoridation. We are looking at initiatives for some of the other smaller communities. There's a new tablet system that is less costly to fluoridate, and we look forward to seeing, I know Sadie's going to a meeting in Missouri to learn more about that in September. I will say another big issue, though, is even though we have good fluoridated water, people tend to drink bottled water. They may not appreciate that our water in Rhode Island is not only healthy and delicious, that it's good for our teeth. So here you can see that not only is bottled water a concern, but soda is a concern. So we want people to drink more tap water. I want to share the work we hope to be doing soon with community health workers. Community health workers can educate in the community to people who have similar lived experience. This is an example from Colorado. So I'm going to play a video. Hope this works.
A mom turned promotora helped push tap water as the healthiest drink option in the 71% Latino Westwood neighborhood in Denver.
Bueno, cuando yo llegué, pensaba que el agua de la llave no era segura y que por lo tanto tenía que hervirla antes de beberla, porque generalmente en algunas partes de la República Mexicana o de Centroamérica el agua no es muy segura. Si no tienes agua y no confías de ella, pues que le das un jugo, a veces les pueden dar un refresco que es lo más común que las comunidades o que todas las familias tengamos en casa.
And kids are receiving these beverages at breakfast, at lunch, as snacks, at parties. And so kids are getting inundated with sugar. And for this reason, we have one of the highest rates of obesity and diabetes in the city of Denver. And we have epidemic proportions of cavities in the community.
Escuché por el dentista de mis hijos que debían de beber ellos el agua de la llave porque tenía flúor y eso les iba a ayudar a proteger sus dientes. Fue cuando yo tomé la decisión de tomar el agua, pues me di cuenta que pues no tenía mal sabor.
Fortunately, Delta Dental of Colorado Foundation was working with local groups to promote oral health and tap water. Westwood Unidos was a good match.
And we realized this is the right fit for us. This is perfect for us. There's so much that's already going on there. There's really not much going on with oral health.
Delta Dental understands that if a community is going to make a change, it needs to happen from the inside out, and the community itself needs to identify the strategies that will work.
The group conducted focus groups and got an idea. They could use promotoras, community members who are trained to promote healthy behaviors among their peers, to push water and oral health. They decided to hire 2 water promotoras. Gabby was first in line.
Así como yo estaba equivocada cuando yo llegué aquí, sé que muchas de nuestra comunidad también lo está. Entonces, para mí era una gran oportunidad de poder pasar el mensaje y de tratar de evitar un poquito que la gente tuviera esa confusión.
In 2015, Westwood and Delta Dental partnered to have Gabby and other promotoras deliver culturally competent oral health and tap water seminars at schools, churches, and other spots.
Aprendimos que le demos menos, evitar las bebidas azucaradas y darle más agua a los niños de beber. En primero, a cuidar los dientitos de leche, que es la primera base que viene en sus vidas.
Pues a mí se me hace bien para evitarles también en un futuro caries en sus dientes y ellos vayan aprendiendo la importancia de beber agua.
No he dejado de venir a todas las clases que da y trato de si alguna pregunta tengo, luego, ¿sabes qué, Gaby? Oye, fíjate que me encontré que este no tiene azúcar o tiene mucho azúcar, ¿cómo ves tú? Y ella investiga y ella me lo dice.
We've reached approximately 500 parents who have participated in the campaign, and we have 14 schools that have already hosted the campaign, and they all are very eager to continue to work with us. We are going to grow next year, and we're going to start working on school policy. We've trained 25 parents to work at their local schools on increasing water and decreasing sugary beverages.
Delta Dental also is taking a long-term, multi-audience approach to change norms around water.
We really want to work with the sports leagues, with coaches, and with moms and dads whose kids are in those leagues to try to create new norms. Hey, rather than juice after practice, let's have water.
Creo que nosotros como papás nos podemos educar y eso va a hacer que nuestros niños estén educados porque van a ver nuestro ejemplo. Si a tu niño no le gusta beber el agua solita por el sabor, ponle fruta, ponle hielo o tenle en el refrigerador y eso de verdad que va a ayudar. Son pequeños truquitos que uno puede aprender y eso nuestros niños lo van a ver y los van a tomar.
So we would love to see this work here in Rhode Island, and we currently have a grant through the CDC Health Disparities grant to have community health workers reach out. And again, our ultimate goal is to reduce caries and tooth decay. So this plays a big role. Okay. So the other important preventive measure for teeth are dental sealants. And hoping most of you have those, but if you're not familiar, it's a tiny plastic coating that goes in the grooves of the teeth that are really the highly susceptible levels of the teeth. And our CLRI program funds agencies to go into schools with high, free, or reduced school meal programs. So that's a directed measure to go to address disparities by bringing a preventive measure to students who may not have a dental home. And it's It's been very successful, however, during the pandemic, with schools not allowing such programs, it's been a challenge. So I hope to resume it soon because we know it works. We've seen the data through CLRI, over 3,300 children received sealants, and over time, we had somebody from CDC help with an analysis that every tooth that doesn't have to have a filling, ultimately it saves almost $175 of treatment, and that results in 9 years of savings. One of our big challenges is getting consents signed by parents, and we believe that that's another opportunity for community health workers to help out, to really into the schools and educate parents. So I am going to turn it back over to Sadie to talk about perinatal and infant oral health.
Great. Thanks, Sam. If you want to go to the next slide. I did want to mention that given that this is a Public Health 101 and you all might be students at various levels thinking about what you want to do with the rest of your life, which seems probably a little daunting, I just wanted to mention that I did not get my MPH, nor do I have an oral health background, but yet somehow I grew very passionate about the work once I started working with the program, and am very committed to the work now. So I just say that as a lesson or a message that you should try anything that sounds interesting. It doesn't have to be exactly what you focused on in school or what you've done in the past. You never know what where your future is going to lead you. So I always just want to throw that in, that even though you may have come in today and been like, oral health, I go to the dentist, there's so much more to it, and there's so much more to learn with it. So give those little options a chance is my message. And really, I bring it up now because this is how I started at the Department of Health, through this Rhode Island POCI project, which stands for Perinatal and Infant Oral Health Quality Improvement Project. It is a mouthful, but we just call it the POCI project, which was basically to improve the number of preventive dental visits for pregnant women and infants around age 1. That is actually our recommended age for children to start going to the dentist, because it not only builds a strong comfort of going to the dentist for children and then adults down the road, it also serves as a chance for anticipatory guidance for parents and to let them know about, drinking a bottle before bed or what to put in that bottle, things like good nutrition. All of those can be done in the dental office starting at age 1. The other piece, which was pregnant women that Sam mentioned, we wanted to improve those numbers that you saw in the data previously. And doing that through, Sam, if you wouldn't mind going to the next slide, through quality improvement, which as you all can tell, everyone supports this. And this is what we like to point out. This is not just the Department of Health in Rhode Island saying that pregnant women and young children should go to the dentist. It's everyone across the country is in agreement. So if you want to go to the next slide, Sam. So what we did in Rhode Island and through this project was quality improvement projects, which is small change that you then grow bigger over time. And so what we did was we started with individual federally qualified health centers doing particular learning labs and projects around getting more pregnant women into the dental office. And as you can see, when we worked with Thunder Mist on the left-hand side, they actually went from 14% of their pregnant women having a dental visit to 31% over the course of the learning lab and the quality improvement project, which some of the quality improvement pieces that they did were warm handoffs for referrals from medical to dental. They also had follow-up calls. They trained their administrative assistants to actually do follow-ups with the pregnant women after their medical visit and say, hey, time to go to the dentist. Let me make that appointment for you. What help do you need in getting to the dental office. So as you can see, there was some great success. You can also see that the use of codes in medical offices also increased, which was for a code for something called fluoride varnish for young children, which is another preventive measure, kind of like sealants, something that's put on the teeth to help prevent tooth decay. So Sam, if you can go to the next. And as I mentioned, we did small interventions, and these are just some of the things that we tried. We created bilingual resources that were about the age 1 dental visit as well as oral health during pregnancy. We made sure they were both in English and Spanish. And the photographs actually were Rhode Islanders. We took photos from like primary photos that we did ourselves. And as you can see, they turned out wonderful. And it's always nice to have that Rhode Island perspective. We also created something called an Age 1 Champion Directory. One thing we heard was that a lot of medical professionals want to talk about the Age 1 dental visit, but they have nowhere to send their families to for those visits. And so we created a Age 1 Champion Directory in partnership with some of our other partners, and it breaks down the directory by location, language. It's very comprehensive. Sammy, you can go to the next slide. And these are just some of the overall results of the project. As you can see, unfortunately, we didn't get quite the increase with we had hoped. Everything kind of stayed along baseline, although there was a slight increase in Medicaid enrolled pregnant women, which we take as a win. And even though we aren't funded by HRSA for this POCI project anymore, we have been doing considerable outreach and education when possible for pregnant women. And next slide. This was our big win, which was the Age 1 dental visit. As you can see where the arrow is, that purple line, between 2016 and 2018, we started the POCI project in 2016, ended 2019-ish. So there was a considerable increase from the start to the end. It ended up being about a 5 to 6% increase in dental utilization for the Age 1 dental visit, which was wonderful. Next slide. I'll turn over to you, Sam, for some of these insurance options.
All right, thank you. So we do know that having insurance is a key factor for people to go to the dentist, and not only having an insurance, but having an insurance that dental offices accept. The Right Smiles program, which was developed about 15, 16 years ago, added a year. They were able to put more money into it so that dentists would actively participate. And this has been a success. I'm going to show you a slide. Let me explain what it kind of looks like, a hump and then a flat line. But it shows on the left side, this is from 2017, that the yellow represents the proportion of, in this case, children having a preventive dental visit, and the blue represents any dental visit. What you really want is for people to go regularly to the dentist for preventive dental care. So this shows the success of Right Smiles in that not only are good proportions, again, would we like to see higher? Of course, but the proportion that are going, they're largely getting preventive visits. That's an investment so that they don't need so much treatment. They won't need the fillings. They won't need the extractions. They'll have their teeth for the lifetime. Less success with adults. So those flat lines that are rising a little bit with age represent adults. And only 15% of adults on Medicaid had dental visits, had preventive dental visits. About 25% had a dental visit. So that means the rest of them are going because they have tooth decay, because they have pain. So our goal would be to let's increase those lines. And the good news, like Sadie shared, is we recently had an increase in the rates, which will go effect shortly. And we hope to engage more dentists so that then more people will have places to go and have those dental homes. We're running a little bit behind. I'll just go quickly through workforce interventions just to tell you that our dentist population is aging in Rhode Island. You can see the largest group is those over 60. That's a big concern. The other thing is that the dentist to population ratio in Rhode Island, that orange line, is decreasing, but also lower than the US. That's also a concern. So we look at that and say, who are the future dentists? The other concern is the future dentists or the current dentists in Rhode Island do not reflect the diversity of our Rhode Island population. So a little bit hard to see, but the area that's orange on the second to last line on the left is the proportion of dentists who are Black or African American. The proportion that's Hispanic is the purple line. But as you can see on the right side that represents all Rhode Islanders, it's the dentist is significantly lower. So we feel that having a robust and diverse dental workforce is important for the patient experience. So we've worked through several ways. We give presentations at schools, and more recently we had a program called the Health Professions Experience, which Jen championed, and we had students in Woonsocket go around and shadow in dental offices. So I know this is a very fast presentation, but we're happy to talk more. Workforce is critical. I hope you'll visit our website where we have a lot of resources. And now this again is our team. I will stop. I'm going to end the slideshow and stop sharing. And now we can take an opportunity. Hopefully you all have some questions. So let's see, end slideshow and stop sharing. So in the remaining time, what kind of questions do folks have?
Sam, I just want to put in a plug. One of the questions we get a lot about fluoridation is if I use a Brita filter, will it get rid of the fluoride? And the answer is no. So continue to use that Brita filter or get one. If you're like, I don't like the taste of my water, but it's fluoridated, feel free to use it. There's only one process that can remove fluoridation or fluoride from water, which is called reverse osmosis. So it's pretty expensive, I believe, and not the easiest thing to get. So you really have to try hard to get rid of the fluoride from a water source.
Yeah, and the reason people use reverse osmosis is if they do have well water, for example, that the fluoride does happen to be at levels higher than 4 parts per million, or in some of those Colorado areas.
I will say I saw, I think it was a toothpaste the other day that actually put itself out. No, it was water. It was a bottle of water that put itself out as using reverse osmosis. And I was like, trash. Recycle. Because I just couldn't believe that they put that out there as something that they're proud of in terms of, I mean, unless it's like you're saying, maybe it's from a very high fluoridated area, but I just couldn't believe they put that.
I mean, there are, like I said, just like there's anti-vax folks, there's anti-fluoridationists, and with a lot of the movements like what is it, Goop, and some of these other things where they try to point out. But I can tell you that there's been significant research that's done on the safety and benefits of fluoridation and through the CDC and other organizations.
All right, it looks like we don't have any questions. I just want to thank you guys so much for joining us. It was very informational, and thank you.
Thanks for having us.
Thanks for having us. Have a good day, everybody. And if you see us in the hall, please say hello.
Yep, and we're in Suite 302 if you want to come by. We're always open.
And if you come by, guess what? We'll give you a free toothbrush.
Yes. Very good point.
And that
right,
includes
thank
those of you who are hearing this on the recording.
Yes.
Okay.
All right. Thank you, guys.
Thank you.
Bye, everyone.
Thank you.